Well, hello, everyone. Thank you so much for joining us for our seminar today. And before we get started, I'd like to offer a land acknowledgement, particularly as yesterday we just had our Truth and Reconciliation Day. So York University is situated on the traditional territorial area known as Toronto, and its current treaty holders are the Mississaugas of the Credit First Nation. And we also acknowledge that this is the traditional area of many Indigenous nations, including the Anishinaabe, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. And this territory is also subject to the Dish with One Spoon Mountain Belt Covenant, an agreement to peacefully share and care for the Great Lakes region. So I am delighted today to introduce our speaker, Dr. Kaitlin Di Pierdomenico. She's a postdoctoral visitor in the Department of Psychology here at York and with the Diverse Mental Health Project. Her research focuses on mental health equity, examining how governance factors influence the design and access and rights to mental health care. She draws on historical institutionalism, Mad Studies and Postpsychiatry to investigate reform processes with an emphasis on person-centered, community-driven approaches. Her work spans topics from mental health reform to digital intervention, with a commitment to building inclusive systems that address social and structural determinants of health. So, Katie, so delighted for you to be here today, and over to you.
Oh, thank you so much, Mary. Okay, so I'm going to start my screen share. Okay, great. Well, good afternoon, everyone. Thank you all for being here today. And a special thank you to Dr. Wiktorowicz and Natalie for organizing this seminar. This afternoon, I'll be sharing my doctoral research, a comparative analysis of mental health reform. So, Mary, thank you for doing the land acknowledgement. I'll just extend that I'm coming from Etobicoke, which is part of Treaty 13 territory, and I work at York University, also covered by the Williams Treaty and Treaty 13. And I recognize the enduring presence and contributions of Indigenous peoples, past and present, and I'm grateful for the opportunity to live, learn, and work on these lands. Okay, so I'm going to jump right in. So yes, if you'd like to write in the chat, or I'll try to be cognizant of anything that comes up, or feel free to interrupt me. But I'll start by sharing a little bit about myself and my background, so and how that shaped my research approach. So my academic path started at Queen's University, where I developed a strong interest in psychology and health. This fascination deepened during my postgraduate studies, where I completed my doctorate in the health department at York University, specializing in health policy and management. And since then, I've been working as a postdoctoral fellow in the Department of Psychology and teaching as a course director. So first in the School of Global Health and now in the School of Health Policy and Management. So like many of us in health research, my interest isn't just academic, it's personal. So as a youth, I watched a loved one struggle to access mental health care. So instead of support, they faced discrimination and rejection. So what I later understood as the othering process of psychiatrization. And that experience left me extremely frustrated, but also determined to push for change. So I stayed connected to community work throughout grad school by volunteering in hospital mental health units, and later collaborating with community partners and nonprofits focused on supporting mental health. So now turning to the focus of this research in my talk today, this dissertation builds on my master's work, which examined mental health reform in Ontario from the area of psychiatric deinstitutionalization, or when people were moved out from psychiatric hospitals into the community, up to Canada's first mental health strategy, which was released in 2012. So early in my doctoral work, I noticed three reoccurring problems. So the first was that mental distress was framed through a risk paradigm. So mental health illness is frequently constructed in terms of risk, right? So risk to the individual, risk to others, and risk to society. And while this biomedical framing can be useful in identifying symptoms and ensuring treatment, it often reduces complex human experiences to medicalized dimensions of danger. And this lens has historically justified coercive practices such as forced hospitalization, involuntary medication, seclusion, and community treatment orders, and which may have been designed with equity in mind, but in practice, what they've really come out to be are institutional care in community settings, right? So individuals are bound to unannounced check-ins and other forms of powerless interactions with care providers. So such practices prioritize control and containment, over one's dignity or recovery or empowerment, and in doing so, they risk undermining trust in mental health systems. So the second problem I noticed was that there was a gap between policy and practice in person-centered care. So health policy documents often champion person-centered or recovery-oriented care, emphasizing individual empowerment and respect for individuals' values and experiences. But in practice, the biomedical model continues to dominate in clinical settings. And this dominance sidelines alternative approaches, grounded in human rights, community support, or cultural perspectives. So, for example, while policies may advocate for collaboration with service users in decision making, institutional routines and power imbalances often mean that patients have limited say in their treatment plans. And the result is a disconnect between the aspirational language of policy and the lived experiences of care. So the third problem was that I noticed that the COVID-19 pandemic exposed gaps in care and coordination. So the pandemic not only made visible, but also in some cases widened the cracks in the mental health systems worldwide. So disruptions in services disproportionately affected vulnerable groups. So including those in precarious housing, low-income communities, or with pre-existing mental health conditions. And lockdowns and service closures highlighted how care was unevenly distributed and poorly coordinated across sectors. And this exposed the fragility of systems that were heavily reliant on hospital-based care, and it also highlighted the lack of equitable, accessible, and integrated supports in the community. So in short, the central premise of my dissertation was that global mental health needs to move beyond a purely biomedical model and toward a coordinated, integrated model grounded in human rights and recovery principles. And of course, while this is aspirational, it requires challenging the structures that currently determine how care is organized and how care is delivered. Okay, so it's important to note that my dissertation's methodological framework was shaped by my earlier role as project coordinator on a SSHRC-funded initiative on realizing human rights and social justice in mental health. So I won't go too much into this project itself, since my wonderful formal doctoral advisor, Dr. Marina Moro, is the project's PI, and I think she's already shared information about that project through this platform. But I just want to highlight how my experiences as project coordinator influenced my research. So in that role, I engaged with international experts, so including individuals at the systems level, to study strategies for making mental health care more equitable and inclusive. So this formative experience sharpened my commitment to rights-based intersectional approaches and showed me the importance of bridging that gap between, global policy commitments and the lived realities of people in distress. And so this work produced two key publications and framed my later research. And I think they were shared ahead of this talk today. But the first was based in Australia, so titled Access and Injustice, an intersectionality-informed analysis of Victorian mental health policy in Australia. And this piece explored how Victorian mental health policy revealed how colonial legacies, systemic racism, and socioeconomic disadvantages shaped unequal experiences of care. So despite reforms aimed at reducing coercion or compulsory treatment and community treatment orders, they were still disproportionately affecting Indigenous and culturally diverse groups. So the key lesson that we took away was that unless social determinants of compulsory treatment, so such as race, poverty, language barriers, colonization, are explicitly addressed, biomedical logics will continue to dominate and justify these coercive practices. So the second article turned to Kenya. So we examined how stigma, discrimination, and chronic underfunding have produced what we called a silent epidemic of unmet mental health needs. And this is because only 0.01% of the national health budget is allocated to mental health. And care remains almost entirely hospital-based, centralized in Mathare National Teaching Hospital in Nairobi. So colonial legacies remain deeply embedded. So laws and policies continue to privilege biomedical coercive responses while sidelining traditional healing practices and Indigenous knowledges. So despite Kenya's ratification of the United Nations Convention on the Rights of Persons with Disabilities, coercive practices such as forced detention and substituted decision-making persist. And just to highlight here, it's substituted instead of supportive, right? So making a clear distinction here, and in clear violation of human rights commitments. So our analysis argued for dismantling these coercive colonial legacies by shifting power toward people with psychosocial disabilities and embracing community-grounded, rights-based support. So this includes investing in community services, respecting choice, and integrating African-centered healing practices within mental health systems. So together, these studies highlighted 3 points that were central to my dissertation. The first was that policies often reproduce inequities, even when claiming to promote equity. The second was that mental health must be understood as a question of social justice, human rights, and structural inequality, and that reforms require community-grounded supports that respect diversity of knowledge and lived experience. So with a human rights and intersectional lens, another key piece of work that critically shaped my doctoral methodology was my contribution to the article Governance of Mental Health Care, Fragmented Accountability, led by my also fabulous supervisor, Dr. Mary Wiktorowicz, who's there with you today. So this paper highlighted how structural and institutional arrangements determine access to care. So of note, Canada excludes community-based mental health services from the Canada Health Act. So this omission, combined with decades of shifting fiscal responsibilities between federal and provincial governments, produced what we termed fragmented accountability. So neither federal nor provincial governments assumed responsibility for ensuring a full continuum of mental health care. So even as evidence mounted that community-based supports are cost-effective and essential to one's recovery. And so this neglect had measurable consequences. So between 1979 and 2014, mental health spending in Canada fell from about 11% to 7% of overall health budgets. And that decline still persists today. So even with the 2017 Health Accord, which injected $5 billion over 10 years into the mental health system, spending still lags behind international comparators, such as France, which is around 15%, Germany around 11%, and the UK around 9%. So my early publications really shaped the methodological framework I later used in my dissertation, and they highlighted how colonial legacy, stigma, and the exclusion of community-based care influence mental health policy, and they also grounded my approach in intersectionality, human rights, and governance. And these insights led me to adopt a comparative historical methodology, so focusing on policy levers, welfare regimes, and rights-based frameworks, and ultimately motivated my investigation into, why does Canada lag behind comparable OECD nations? And in my particular focus, I looked at Canada in relation to the UK and Australia in advancing meaningful mental health reform. So to make sense of mental health reforms across Canada, the UK, and Australia, I grounded my analysis in 4 key perspectives, so informed by my theoretical background. So the first was historical institutionalism. And so this sees healthcare systems as legacies of past political struggles and decisions. So this built on my master's framework, which relied on power resource theory. And so power resource theory emphasizes, who holds power and how they use it ultimately shapes policy outcomes. So historical institutionalism allowed me to ask, what kind of reforms are pursued, who is pushing for them, and under what kind of conditions do they succeed? I also drew on Esping Anderson's typology of welfare states, and this explains how different, countries structure social supports and distribute power. So this was crucial for understanding, how broader welfare regimes shape not only policy outcomes, but also underlying assumptions, like whether mental health care is seen as an individual responsibility or a collective one. And finally, I incorporated perspectives from postpsychiatry and Mad Studies. So postpsychiatry challenges the narrow biomedical approaches and reframes distress in social and cultural contexts, while Mad Studies is grounded in lived experience, so pushing for a holistic view of distress that considers one's social and economic conditions. So these perspectives kept my analysis grounded in human rights and community voice. And so ultimately, I wove these 4 perspectives together. So institutional theories, such as historical institutionalism, excel at explaining how reforms get locked in or how they stall, but they often miss, what's happening on the ground. And so that's where post-psychiatry and Mad Studies help to fill that gap, keeping me focused on, whose voices are excluded, what kind of reforms could make mental health systems more inclusive and more equitable. Okay. So now that we sort of talked about my methodological framework, let's turn to the specific methods I use. So to answer my research question, again, why has Canada lagged behind comparable nations in mental health reforms? I used a comparative historical approach, so which examines how long-term political and economic trends shape reforms over time. So this approach is especially useful for understanding, how big picture structures like healthcare and past decisions can limit or enable what is possible in health policy today. So my main methods included an archival policy research, so where I reviewed national and regional strategies and funding models, document analysis, so where I traced how reform goals were developed, communicated, and implemented. Again, paying close attention to whose voices were included in these document analyses and who were not. And my archival sources included advocacy group records and community agency reports. So these provided both historical context and on the ground perspectives. And I chose to focus on documents from the 1980s onwards. And this choice was, I thought it was sort of close to the period of psychiatric deinstitutionalization across the three sites. And I used reform words like community-based care and integration to guide my search and my search of policies. Okay, so the case countries in my study were Canada, Australia, and the United Kingdom, which are each a parliamentary democracy, but they have very different mental health governance structures and levels of privatization. So I narrowed my analysis to the provinces or states of Ontario in Canada, England in the UK, and Victoria in Australia. And each of these states have very active reform efforts, and they also had rich data sources. So this focus allowed me to capture, how national and subnational governance interact in shaping mental health policy. And so to give you just a quick comparison of healthcare organization across the three case countries, Canada has a publicly funded Medicare system that covers physicians and hospitals. The UK has a centralized public national health service alongside a growing private sector. And Australia has a public Medicare system, but with a larger private insurance role than is present in Canada. So using the comparative historical approach allowed me to see not only what policies were introduced, but also how each system responded to similar challenges, challenges such as like underfunding in mental health care, gaps in access, and calls for more personalized care. So with my methods in place, I structured the dissertation to move from setting the stage to analyzing how levers were used to drawing lessons across countries. So in the introduction, I outlined the key levers shaping reform. So how healthcare is structured, how it's financed, and how it's regulated. I also identified political windows of opportunity, right? So these are areas where change was likely to happen or could happen, the conditions that were favorable. As well, I went into institutional levers. So these levers, I examined each lever in each chapter, and I wanted to see, how were these levers either applied or neglected? And then in policy and practice, I focused on how reforms connected or failed to connect to human rights goals and what community organizations were experiencing on the ground. And finally, the comparisons and lessons section, I was able to draw out what I learned across Ontario, Victoria, and England, comparing the pace, the scale, and equity of reforms. So to explore each section in more depth, in the first section, I examined the policy levers of governance, then finance, service system design, and professional regulation and payment. And again, across the three sites, roughly from the period of psychiatric deinstitutionalization up until the 2010s. Okay, so the first lever I looked at was governance and government structure. So in exploring each site's history, a clear theme emerged. So integration was the dominant response to mental health reform. So moving care out of institutions, involving people with lived experience in policymaking. But the way this played out differed depending on the country. And the 1990s brought big shifts across three sites. So in Canada, healthcare became one of the most contested issues between federal and provincial governments. So in Ontario, the end of 40 years of conservative rule in 1985 opened the door to new ideas, especially around community care. But again, because provinces hold most of the power, reforms were often uneven and slow. In the United Kingdom, the National Health Service introduced something called the purchaser-provider split. So the idea here was to make providers more efficient by creating competition for purchaser contracts. though in practice, it often pushed the system to focus more on cost savings than patient experience. And then came the devolution in the late 1990s. So powers over health were handed down to Scotland, Wales, and Northern Ireland, while NHS England took charge of England. Now, in Australia, like Canada, Australia is a federal system, so where states and territories control health. But the key difference is that the Commonwealth, or the federal government, has played a stronger leadership role. So, starting with the 1992 National Mental Health Strategy, the Commonwealth coordinated national plans and provided targeted funds to push states toward reform. So by the 2000s, all three countries started talking about this whole of government approach to population mental health. So recognizing that mental health isn't just biomedical or centered around doctors and hospitals, but also involves social determinants, right? So housing, education, employment. So in terms of government control or centralization, the UK was the most centralized, with the NHS England driving the mental health reform agenda. Canada was the most decentralized, with provinces mostly in charge of dictating reforms with very little national coordination from the federal government. And Australia fell between the two. So it had more national coordination through the Commonwealth than Canada's federal government. So when comparing financing and service system design, key differences stand out. So all three countries are liberal welfare regimes with universal systems, but they redistribute differently. So Canada limits first dollar coverage to physicians and hospitals. Australia provides broad coverage with significant co-payments, and the UK sits in between. So by the mid 1980s, market-oriented reforms introduced hybrid actors. So these were organizations that blended public mandates with private sector funding or management, and they were increasingly shaping mental health policy. And this brought tensions. So community advocates pushed for inclusive, rights-based services, medical professionals defended their clinical control, and lived experience was starting to gain more recognition and more momentum. So together with efficiency pressures, these dynamics fueled what we call managerialism, or the use of private sector tools like performance targets and outcome metrics. So while systems started to look more accountable on paper, this managerial focus shifted from quality of care to measurable outputs, so often at the expense of patient experience. I know this is a scary slide, so hopefully it won't be as scary as I talk through it. But looking back at the big financing and reform moves, we see in Canada that the federal role in mental health funding was historically small, right? So the 50-50 federal provincial cost sharing of the 1960s dropped below 15% by the late 1990s. So even when health budgets were growing, mental health received only a small share. In the UK, and again, my analysis shifted to NHS England after healthcare devolution in the 1990s. Major 1990s reforms brought market principles into the NHS, so creating mental health trusts. And these were regional National Health Service organizations responsible for delivering mental health services. So they were given budgets and a degree of managerial independence, so they looked more like businesses within the public system. And importantly, NHS England started to ring fence mental health investments. So we can see there was a $700 million between 1999 to 2001, plus 300 million in the 2000 National Health Service Plan. So ensuring that funds were dedicated to mental health budgets, so unlike Canada. And in Australia, the 1992 National Mental Health Policy was a turning point. So it launched a series of 5-year national mental health plans. So as you can see, 1998, 2003, and so on. And each was tied to new financing. So by 2009, Victoria's reform strategy had invested $128 million over 4 years in prevention, early intervention, and recovery. So of the three, Canada received the least consistent and targeted investments in mental health, so both in scale and in financial accountability mechanisms. The UK and Australia, by contrast, paired reform strategies with dedicated funding streams. So this created clearer pathways for implementing policy changes. And so hopefully what is becoming clear is that the levers of financing, service system design, and governance are deeply interconnected. So in Australia and the UK, more centralized governance and fiscal responsibility enabled faster, more coordinated reforms. In Canada, decentralized provincial funding made large-scale reforms slower and less consistent across the country. So another important lever is professional regulation and payment. So especially for general practitioners, so who often act as gatekeepers to mental health care systems in the public sector. So in Canada, regulation happens at the provincial level, so which means that standards and scopes of practice can vary across provinces. In the United Kingdom, regulation is centralized under the General Medical Council. So there's a single set of national standards for doctors. In Australia, in 2010, a national registration and accreditation scheme was introduced under national law. So this harmonized standards across the country. So across all three countries, there has also been a strong push towards interprofessional collaboration. So bringing together GPs, psychiatrists, psychologists, nurses, and social workers to improve care pathways. And this momentum grew during COVID-19, but what we still see is professional territorialism, right? So competition over roles, over scope, over authority. And this still limits integration in practice. So in the early 2000s, each country started experimenting with integration care pilots to expand access and better connect services. And most of these focused on psychological care, given how much of it still operates in the private sector. So in Canada, we saw Ontario's shared care site, so linking psychiatrists with family physicians. In England, they introduced the Improving Access to Psychological Therapies program, which expanded publicly funded access to talk therapies within its public system. Australia Better Access Scheme under Medicare increased coverage for visits to psychologists and GPs for mental health care. So after examining the policy levers, I then looked at policy and practice. So looking at changes that occurred from the 2010s up to present day mental health reforms. Okay, so key takeaways here. So integrated care was a shared commitment across Canada, the UK, and Australia, but each country moved at different scales and paces and with different policy levers. So rights-based legislation often fell short in practice. So for example, the United Nations Convention on the Rights of Persons with Disabilities guarantees autonomy, community living, and freedom from unwanted treatment. Yet coercive measures like community treatment orders remain in use, and these directly contradict these commitments. So in other words, countries sign these treaties, but still maintain practices that undermine it. And community service agencies across all three countries consistently were calling for greater investment in community-based supports. So despite investments, they haven't been able to keep up with the scale of needs and the scope of supports that are required. So there were some clear patterns. So looking across cases from the 2010s to present day, the pattern that we noticed earlier is sort of staying intact, right? So countries with dedicated ring-fence funding and clear accountability structures, like the UK and Australia, were able to advance reforms more quickly and consistently. Canada, by contrast, moved slower and more unevenly, largely because funding wasn't consistently protected or tied to measurable commitments. And so some concrete examples of this is chronic underfunding in Canada, which is often called structural stigma. So the 2017 federal pledge of the Health Accord was historic, but it lacked accountability mechanisms, so limiting its impact. And this is similar to the 2023 Liberal federal budget, which provided $2.5 billion over 10 years, and the Ontario provincial Conservative budget in 2020, which provided $3.8 billion over 10 years. So while programs like Mindability, which are supposed to provide cognitive behavioral therapy for youth, have been put forth, again, accountability on measures and outcomes are poorly reported. And, so we don't know how this money is being spent or who is being accessed or who is being reached. And this is in contrast from examples from other states. So in the United Kingdom, the NHS long-term plan committed $2.3 billion annually by 2023-2024, and this was alongside targeted strategies to reduce racial disparities in mental health care. In Australia, the 2022 Mental Health Strategy and Suicide Prevention Agreement was allocated, formally linked federal and state investments. And in 2023, $7.5 million was allocated to support national lived experience advocacy bodies. So again, so we can see a lack of clear directive and accountability outcomes. that guide federal and provincial funding of mental health in Canada as compared with the other states. And finally, I focused on the lessons learned across countries, so comparing the pace, scale, and equity impacts of reforms. And again, in looking at comparative patterns, we can see that there are shared challenges. So across all three, funding for mental health has lagged behind physical health. So it's a persistent structural inequity. Reform has always been shaped by neoliberal logic, so emphasizing cost control and efficiency, and biomedical dominance, so prioritizing risk management, cost, and clinical treatment. And this has produced ongoing tensions between treating mental illness as a risk to manage and addressing needs for support while also upholding rights. So even when integration was promoted, it was often reinforced biomedical authority rather than shifting power to community-based or rights-based approaches. Second is that policy communities act as both levers and outcomes of reforms. So policy networks themselves become part of reform. So in Australia, advisory groups were mandated from the 1990s, and more recently, 7.5 million, as I mentioned, was invested in lived experience peak bodies. So in Victoria, consumer consultants hold paid and roles, and co-production groups actively shape policy. In the UK, traditions of community feedback stretch back all the way to 1970s. So now they're institutionalized through bodies like Healthwatch England, and these mechanisms mattered, not just symbolically, but substantively. So embedding lived experience and community voices into the policymaking infrastructure. So in Canada, by contrast, these kinds of formal structures were far weaker. So while advocacy groups such as the Mental Health Commission of Canada, which was founded in 2007, raised the profile of lived experience, most provinces lack sustained institutionalized mechanisms to fund or embed service user leadership. And this has meant that, community voices are often influenced through ad hoc consultation. So rather than being consistently built into the governance process. Also, governance and managerialism. So all three countries adopted managerialist tools like performance targets, audits, and benchmarking. The UK embedded these earlier and more comprehensively, so linking them to national strategies and central oversight. And that gave both the UK and Australia a head start in aligning funding, governance, and service standards. By contrast, Canada's weaker federal role and fragmented provincial systems has meant that reforms were less coordinated and less consistently monitored. So the fourth pattern was divergent reform pathways. So in Ontario, integration strategies were introduced, but without sustainable funding mechanisms until much later, so limiting their impact. In the UK, reforms were tied to financial incentives, so such as ring-fenced funding and payment by results, so directly linking resources to outcomes. Australia undertook large-scale structural reforms, like programs like the National Disability Insurance Scheme and the Psychosocial Support Program. So this expanded the federal role in providing public service delivery at scale. And finally, regionalization and local autonomy. So all three countries moved toward regionalized or devolved systems, but with different balances of power. The UK maintained strong national control through NHS England. Canada leaves far more to the provinces, resulting in greater variability. Australia blends both, so using federal state agreements to steer priorities while also leaving service delivery largely to the states and territories. Okay, so the analysis highlights significant differences in the scale and pace of mental health reforms across the three countries. So by examining the institutional levers they employed, how these shaped policies in practice, and what lessons can be drawn from the era of psychiatric deinstitutionalization to today's reforms, several patterns emerged. So UK and Australia advanced more quickly and at larger scale, backed by ring-fenced investments, national strategies, and legal frameworks that mandated reform. Devolution in the UK and federal state agreements in Australia provided central levers to drive implementation. In Canada, reforms were slower and more reactive. Federal provincial division of powers left mental health outside the core insured services of the Canada Health Act. Funding for mental health has historically been marginal. so often make community services the first to face cuts during fiscal restraint. And there's also been shared challenges. So all three, deinstitutionalization promised community-based alternatives, but investment has lagged behind need. So advocacy continues to push for a sustained community investment and for aligning reforms with rights-based care. So including commitments that have been signed on under the UNCRPD. So this research makes several contributions. First, it offers a comparative historical institutional analysis of mental health reform, so showing how systems evolve across different contexts. Second, it brings together post-psychiatry and Mad Studies with system-level policy analysis, so creating space for critical perspectives in a field that is often dominated by biomedical framings. Third, it incorporates policy community perspectives, so highlighting how reforms are experienced on the ground. And taken together, this shows us how governance structures, funding mechanisms, and community participation all shape reform outcomes. And it reminds us that, global mental health reform is not only about what works, but also, what works, where, why, and for whom. And so answering that requires both structural analysis and the voices of those living the realities that we're trying to change. Of course, there are limitations. So the institutional lens helps explain how systems evolve, but they tell us less about, why particular levers were chosen. So interviews with policymakers could have added, valuable insight here. And while I drew on service agency perspectives, there's still a gap when it comes to grassroots lived experience voices. So including those voices more directly would add an important depth to this research. And then looking forward, some directions that this research, maybe could take is one is to, use insights from policy levers to design for reform models that are sensitive to each country's structures and historical trajectories. Another is to strengthen financial and legal frameworks, so learning from mechanisms employed in the UK and Australia. Embedding equity into governance, so building accountability structures that target disparities, such as racial inequities or the divide between rural and urban service gaps, so not just overall system efficiency. And finally, reform should integrate community voices at the policy design stage and treat cross-country comparisons as a continuous feedback loop, so countries can recalibrate based on each other's successes and missteps. And so, as Mary mentioned at the start, I am now a postdoctoral fellow in the psychology department, where my work focuses on advancing equity in mental health systems and the delivery of e-mental health care. So my background in comparative policy analysis and institutional theory allows me to assess system effectiveness, so both quantitatively and qualitatively, and link those assessments to the lived experiences of communities most affected. So my dissertation showed that, unlike Australia and the UK, which has expanded access through legal and financial mechanisms, Canada has leaned heavily on e-mental health care. And this reliance grew during COVID-19 as digital tools became central to service delivery. So increasingly, this has meant turning to hybrid actors, so public-private or community academic partnerships, to develop universal mental health apps or online therapy platforms to fill system gaps. So building on that, I've led a scoping review and meta-analysis of universal population level digital interventions for children and youth. And we found key gaps. So one of them is, younger children and marginalized groups are very much excluded from this research. While hybrid models, so these are that combine digital delivery with some form of person support. So for instance, using an app in school for kids tends to yield the most long-term lasting impact. As well, that social psychological outcomes remain especially undersupported. And this is a serious concern given how much, youth lives are now digitalized, right? How technologies have been increasingly shaped their day to day. So now in my second year of my postdoc, my research looks more directly at the policy levers of regulation, governance, and finance. So I'm asking, how can these be structured to make e-mental health more equitable? And as part of the Divert network, which is a CIHR-funded project under my supervisor, Dr. Rebecca Pile-Riddell, I've had the opportunity to engage in listening tours across the nation. So gaining system-level analysis, of ways in which technology can improve the mental health care system for marginalized populations. So taking together, this work connects my background in comparative policy with my current focus on digital mental health, showing how system-level reform and community experiences need to come together if we want real equitable change. And so this slide is just the references that some of them that I've mentioned. And I just want to thank you all so much for listening and for giving me the opportunity to share my research with you. I have my email on the slide if you would like to connect with me, and if about my research or my current work. And yeah, thank you so much. I look forward to discussing.
Well, thank you, Katie. That was really excellent to have that incredible overview of 3 different countries' approaches, and also the way you've melded different theoretical lenses to support that work. So let me just begin with one question, and then we can open it up. So Canada and Australia seem to have the most similarity in terms of their governance structure, both being federal states with the provinces or the states having a lot of responsibility for healthcare delivery. And I noticed there were some interesting things that Australia did, like tied federal funding for mental health to, I guess, the states kicking in some matching funds. So I'm just wondering if you can expand on that. Do you see that maybe as one of, kind of a promising approach, or what would be some others to kind of get Canada to be less of a laggard, so to speak?
Yeah, absolutely. I think that like shared governance or network governance, which is sometimes what Mary, I've learned from you, is very important, right? So in Canada, the division is, the federal government with the health accord, they may invest money in mental health care, but it's up to the provinces how they want to spend that money. And so with these federal state agreements in Victoria and in Australia, it's a strong commitment of this is going to be the outcome of the funding that we're matching. So tying, clear measurable outputs to that funding, and can't be spent in a different manner.
Yeah, it seems that we're missing that, even with the $5 billion that was to be directed to mental health by the federal government a few years ago. I don't know, I think you referred to there's kind of unclear how those funds have been spent and what impact they've had. All right, great. Well, thank you. So go ahead.
Hello. Thank you. That was an excellent presentation. I was just thinking, based on the readings. Oh, sorry. My name is Chelsea. Based on your presentation, it was talking about how reform efforts, they often take a very long time with the system level barriers, with the strategy processes, funding, and decision making. But I was finding kind of a common trend between the 3 papers shared about the ones that are feeling the gaps the most, or those from marginalized communities, and are more reliant on the local implementation processes. So I was just kind of curious and wanted to open up the discussion on how can these different levels in systems together, from local, provincial, federal, kind of work better together to make it a more equitable system, kind of from your perspective.
Right. And no, I think that's a fantastic question, because I think, and it was funny, I think it was one of my external reviewers' comments was, this just sounds all so aspirational, right? And it's like, there's a lot of structural changes that need to happen. And I think the biggest lesson so far is in my postdoc work, which is we have these good intention, we can do this research and we have these good intentions of mental health care is going to fill the gap, and we're going to, reach these underserved communities. And then when you're actually in the communities and you're listening to them, you realize, that's not going to fit, whether or not it's internet challenges, access to technology, access to quiet spaces in order to do the therapies. So there's a lot of disconnect, between what is happening at the federal, provincial, system providers, as well as, service users. And I think that one of the critical piece in that is really having, community perspectives. And we see that in Australia, and we see that in the UK, where it was mandated pretty much right from the start, as soon as we started talking about mental health strategies, that there were paid roles for community experts. And in Canada, we tend to, do the change, and then we say, what do you think about it? And so there's a massive disconnect. I don't know if that answered your question, Chelsea, I hope. Oh, okay.
Thank you.
I think, Abe, you had your hand up first?
Well, hello there.
Hi, Abe.
Hi, how are you? Amazing, amazing. It's so lovely for me to see your work. Because we haven't talked in a while, and it's awesome. So, I'll try and be brief. You in your presentation, you're talking about the different way. One of the things you were saying is the different ways that they've approached kind of allotment of funding, and there's a mixed approach, and all the different things, how that kind of ends up happening. I stepped away for a bit, so you might have answered my question. But my question is, as you've done this research, as you've worked with community, from your perspective, what is the most effective way to, I guess, a lot of these funds or organize this, approach this problem that you've kind of highlighted, right? Like, how would you personally at this moment say, okay, I think I'd lean in this direction or that direction? Is that, I don't know, is that clear, that question? Yeah.
No, I think it's absolutely clear. And I think one of the lessons that I just learned recently is, and I don't have all the facts here, so I'm sorry, bear with me, but, after COVID-19, there were certain mental health targets, right, that were, we're going to invest this much in Black community mental health. And what happened is a lot of these communities didn't receive that funding, number one, and number two, they didn't have control on how to spend that funding. So, mental health is extremely cultural. It's extremely locally based on needs. And so I think that's the whole piece of, you got to include the service providers. There's got to be greater connection between the various stages of mental health delivery. Because if we're delivering the care and we're saying, this is what we think is best, these communities don't deliver care in that manner. So really aligning with community priorities and what the needs actually are in that local context. What we have here and our access issues here are extremely different than what the access issues are in the north, right? Or also, culturally appropriate care and whatnot. Oh, sorry, I think you're on mute.
And a quick follow-up. Did you find that, like, in your research, did you find that outcomes tended to be, like, was there data around health outcomes, I'm saying, being, maybe better in the UK with their approach, or Australia with their approach, or Canada with their approach? And if there are, how did those break down, I guess, that's my follow-up. But thank you so much for your...
No, absolutely. So I think that that was the piece that that was my passion, was being able to see, these policies, and at face value, they look great. They hit all the targets. We need greater integrated care. We need greater investments. But what I saw is the difference between the responses in the community service agencies in the UK and Australia is that, the same response was that we need more, but they actually were doing what they were doing. So reducing racial disparities, or improving, the number, reducing wait times for youth in the ER. Whereas in Canada, we didn't have those targets. So we don't even know where we stand. We couldn't even really look at that. I can continue on. Okay.
Thank you. That's really interesting how, we don't even try and measure, and maybe it's a way to evade accountability.
Yes.
Yeah. Olena, you have your hand up.
Yes, hi everyone. Thank you very much, Kaitlin. This is an amazing presentation. I'm actually doing my research on mental health, children's mental health, specifically focusing on like neurodiverse children. And I'm looking for it from like a system perspective, but more from system integration perspective rather than just policy. So more like a technical perspective. And from what I've seen here is the data, it's either super fragmented or non-existent to begin with. My question is, have you seen in any of the countries that you've analyzed, like UK or Australia, have you seen any system that is semi-integrated or connected, not only focusing on like more of significant psychiatric kind of conditions, but less like more of a neurodiversity, and especially in children, because we have OMARS here, right, in Ontario, but I haven't seen much of the data or information with regards to like 0 to 18 population.
Yeah, and I hope I'm not going to take this on a different direction, but what where I found that biggest gap was in regulation of providers. So in the UK and Australia, they're centralized, right? So providers can move freely between states, between countries, whereas in Canada, we're provincially regulated. So, so most of this e-mental health sphere is going to be produced by psychologists, by psychotherapists, by social workers, but we can't mobilize them where they need to go. Or, and what we've been finding is that individuals want to have someone who will understand, when they're talking about mental health or counseling or talk therapy, they want to talk to someone who understands their lived experience, right? So someone who knows whether or not they have that lens, that trauma-informed lens. And so that regulatory piece really restricts access to care. And in terms of systems level integration, I think, again, it kind of goes back to really involving, service providers as well as service users in the organization of care, in the design of care. A lot of the care design, especially in Canada, operates in isolation with provider's voice, right? And I think that, mental health care, it is so heterogeneous where you are in Canada and what community needs are. And so we really do need that local piece, those local perspectives, those local systems in directing their own care. And that's where like the idea of personalized sense, person-centered care or personalized care, I know it can take root in ideological frameworks, but the whole idea is that we should be able to determine what kind of care we want, right? And what kind of mental health supports we need. I went on a tangent.
Yeah. So I have two quick questions. One is, in Kenya, 70% of their revenue is for debt servicing. So by the time they finish paying for the army with UF weapons, I'm surprised they have money left for anything, right? So is that number not, I think it was 0.7%?
Yeah.
Is that not probably in the scheme of things reasonable? And the other question is, you mentioned neoliberalism, which is basically, I call it the Hitler form of management, where authority is top down, but responsibility is bottom up. But basically, what it means is the accounting department has taken over control of the administration of healthcare and the delivery of healthcare. Is that fair?
So I think, okay, I'll address maybe question 2, and then I'll go back to question 1. So I think the neoliberal framework is harmful in the sense that it really has applied this risk management of individuals, right? We, with the managerialist framework, there is good outcomes, right? Like we do see in Australia and the UK, when you do apply targets to funding, we meet those targets. So it's not all bad. It's just like at what expense, right? If it's at the expense of service user experience, then it's not working, right? If it's about how many patients can a psychiatrist see in an hour versus how many, patients does a psychiatrist see and treat and actually give a recovery plan to in an hour, right? So it's that balance of these measurable outputs that have come out of, neoliberalism. If they are incorporated in a human rights perspective, they can be beneficial. But if they're taken up at this risk management at the expense of patient experience, then they can be very harmful. And then, and I think your first question, so mental health as a share of overall health budgets. Yeah, I think that the issue is more so, of course, you only have so much of a pocket to pull from in case of, how much of the healthcare budget you can devote to mental health. But I think the issue is like how mental health is structured, right? So it's completely institutionalized. It's in the Mathare National Teaching Hospital, where a large part of African-centered mental health care is delivered outside. Right. And so actually community mental health care, I don't know the exact percentages, but they fill majority of mental health gaps. So it's not so much, it's a restructuring of the mental health care system to better meet needs in Kenya. and the fact that it's centralized into the hospital can be very harmful.
So it's not so much the money, but the allocation of the money.
Exactly. Yes.
Well, I'm depressed.
Hi,
No, I
Kaitlin.
know.
Hi, Kaitlin. This is Kadirvel. So I'm also kind of trying to use the institutional approaches or institutional lens for my research in exploring the global governance of antimicrobial resistance. I think this is a fantastic presentation you presented on how the meta governance is working in these three different countries or places in mental health reforms. So my question is related to how the global governance mechanisms are actually kind of influencing these mental health reforms in these three different settings, because of course there are, as we classify countries or identify countries with different levels of governance, as we heard in the past speakers that one of the province in Canada didn't share any data during COVID time, and they shared the data after showing some documents related to WHO or some big multilateral organizations documents saying that this is needed for reporting purpose and in something related to international health regulations. So, and despite the federal government approached them, they didn't share it, but they shared it after showing the IHR documents or related documents. So how that's related to this observations. So how these global governance mechanisms actually kind of influencing the mental health reforms?
Yeah, great question. I think that, first of all, I chose 3 high-income countries, parliamentary democracies, right? I think we have to, and I think that's where the Kenya piece hopefully was able to show such a difference, right? Of, how little is spent in mental health care, how historically biomedical the whole system is structured, right? I think these, international human treaties like the UNCRPD are so, wonderful in design, again, what's stated in policy, and these countries, have signed on to them, they've ratified them, but then you have to look at what's happening in practice, right? So like these community treatment orders, substitute versus supported decision-making. So these are all in direct violation of human rights obligations. But yet, people get, countries get away with it. So yeah, I don't know if that was really an answer to your question, just more that, these, there's not a lot of punitive mechanisms if you don't uphold these treaties, because we're not.
Yeah, enforcement mechanisms.
Yeah.
Yeah, no, it is a challenge. But I think, Catherville, you suggested that in the case of COVID and data sharing, it could be used as a tool. And so, but I guess for example, in Canada, we haven't used reference to the Human Rights Convention to push provinces, if you will, to do more.
Well,
but
yeah.
Maybe as a lever, just
and
from the COVID.
Yeah, and I think the federal government knows, right, that, there's only so much money in the pot, right? So, and that because they're not able to kind of steer provinces or able to influence provinces as much as the Commonwealth and Australia is by saying, hey, we're going to match your funds, we're going to join a partnership, right? Provinces are going to spend their money however they see fit. Whatever the needs, political voices, whoever voices are heard, that's really going to direct, where resources go. And so I think that's where like governance and accountability is just that's the clear director of, how finances are spent. Yeah.
Yeah, that's great. Okay, well, I guess we've reached the end of our time, but thank you so much, Katie, for enlightening us all with your really insightful comparative analysis and also your blending of the different theoretical perspectives that I think explains a lot more than, any one of them alone could. So kudos to you for that innovation, and thank you so much.
Thank you.
And yeah, you have a book coming out, right? With you're working on a book.
I'm working on a book, yes. But thank you all so much, and thank you for the discussion. It was really great to go back there. I feel like because I'm now so systems focused, that it's great to go back into the policy and the structural issues that are influencing the day-to-day and what is happening. So I appreciate discussing with everyone.
Well, thank you, Katie. We look forward to your book coming out.
Thank you.